Thank you, and good morning, everybody. And my thanks to David and Mike, as well as the AUA Office of Education and the industry sponsors for this. I think this is the eighth year. I'm losing. Oh my God, 10th year? Okay, I really lost track of time. So thank you all for being here with us today. So my job in the next few minutes is to kind of give you a lowdown on genetic testing and prostate cancer. This is a very rapidly evolving area for those of us in urology. Medical oncology has been in the world of genetic testing for a long time before we got involved in urology. Nonetheless, this has had a major impact on our approach to our patients, particularly with advanced prostate cancer, but now, as you'll see, earlier stages of prostate cancer impacting screening and other approaches to the disease. So first thing we're going to talk about is the background. So a lot of what you're seeing all across medicine and precision medicine is due to the completion of the Human Genome Project, where we mapped the entire human genome. It took about 13 years to do that. But in reality, it was only about 2 or 3 years ago where that last little bit of the human genome was actually completely mapped by the project. I show you this iceberg because right now, we're sort of at the top there where we have a little bit of understanding about BRCA1, BRCA2, but there's a lot more genetic information out there in our DNA that as the years go on, we're going to be figuring out exactly what do these different genetic components mean to us in a whole variety of diseases far beyond prostate cancer. But with this background, it's important to remember something that really happened in 1999. And it was in 1999 that the Breast Cancer Linkage Consortium, again, this is the last century, kind of said, hey, we think there's a connection between BRCA1, BRCA2 in male breast cancer, maybe in prostate cancer and the like. So the concepts have been with us for a while, but it's taken really over the last 10 years or so where we kind of figure out how are we going to use this information on genetic testing and prostate cancer to manage our patients. So something else very interesting happened about 12 years ago, and that was in 2013, where there were two major events in the world of genetic testing in general. The first was Angelina Jolie, who made a very important and passionate plea to the world that you can inherit cancer from your parents. Before then, we kind of knew that in medicine, but the public at large didn't realize that there was genetic predisposition. Well, her story with hereditary breast and ovarian cancer really got everyone's attention. The other interesting thing that happened in 2013 was the Supreme Court came out with a ruling that DNA could not be patented. Before that time, since the mid-1990s, when BRCA1 and BRCA2 were first discovered, there was one company that basically had the lock on BRCA1 and BRCA testing. When the Supreme Court came out with this, there was an explosion of not only commercial interest, but research interest in looking at the whole area of genetic testing. So to bring this down to prostate cancer, this is all very new to us. In fact, here's a timeline. Before 2016, prostate cancer and the breast cancer genes were really only discussed in the hereditary breast and ovarian cancer guidelines. And finally, in 2016, was the first mention in the NCCN guidelines about family history of BRCA1 or BRCA2 genes maybe influencing if a man should or should not be screened for prostate cancer. Well, finally, in 2017, the NCCN guidelines actually nailed down the first familial and hereditary genetic considerations for screening. Later, the update in 2017 was the first mention of PARP inhibitors and DNA repair for potential therapy. In 2018, it was mentioned to consider germline testing, and then by 2020, it was considered to be mandated that if you have high-risk prostate cancer or strong family history or newly diagnosed metastatic prostate cancer, you should undergo genetic testing. So we were very fortunate in Philadelphia. We jumped on this bandwagon back in 2016, 2017, and we sponsored the first two international consensus meetings on exactly how should urology approach genetic testing for prostate cancer. And we gathered this really eclectic group of medical oncologists, radiation oncologists, but also breast cancer researchers, ovarian cancer researchers, bioethicists, basic scientists to come up with some recommendation. And a lot of these recommendations now have been booked into a lot of our NCCN, ASCO, AUA, and other guidelines. So that's kind of our basic background. So with that background, let's now talk about some very basic concepts to those of us that are new to genetic testing and prostate cancer. So this is now, I think, fairly dogmatic in our field of urology and urologic oncology, that there are germline mutations and there are somatic mutations. And basically, the germline mutations are the mutations in genes that you can inherit from your mother, your father, your grandparents, and the like. Somatic mutations, I like to call the wild, wild west of the tumor. The tumor can develop all sorts of crazy genetic alterations that cannot be inherited or cannot be passed on to the next generation. In general, germline testing you can do with blood or a saliva sample, commonly done. However, for somatic tumor testing, which is becoming very important, and it's going to be a theme of a lot of the subsequent talks you're going to hear about today, you really need to use fresh tumor, archival tumor, metastatic tumor, or the area of growing liquid biopsy where you can actually get a blood sample and snare some of the exosomes, the CTCs, cell-free DNA that may be out in the circulation relating to the tumor. So these are two core concepts that you have to follow through if you're going to get involved with genetic testing. When we talk about this genomic testing, the words are kind of interchanged right now. They're really not a clear division between the two. But I like to point out to everyone that there's sort of, to my view, three big buckets. There's genomic profiling, there's genomic tumor sequencing, which is the somatic testing, and then there's the inherited risk testing, which is germline testing. What we're going to be focusing on today is really the somatic testing and the germline testing. The genomic profile is something that we're all very familiar with. It's looking at specific, mostly mRNA species in the tumor biopsy itself, things like Decipher, Prolaris, Oncotype DX, that help you with outcome and treatment decisions. But that's not what we're talking about today. What we're talking about is looking at very specific genetic and genomic alterations, either in the patient's germline or in the patient's specific tumor. So, you know, the amazing thing about this is if we did not have computational biology, we could not figure this out. Here's just one example of a very small piece of exon 11 of the normal BRCA2 gene. And this is all just a whole bunch of machine language. And if we did not have computers to help us figure out where are the mutations specifically, where are the gene alterations or the inversions, it would be impossible for us to be doing what we do. So we're very heavily dependent upon commercial laboratories who are able to do this very, very easily for us. And again, to remind everybody, we talk a lot about BRCA1 and BRCA2. They're kind of the grandparents of this whole discussion, and they stand for breast cancer gene, originally discovered, as we mentioned, in the Ashkenazi Jewish population in the mid-1990s that laid the foundation for everything that we're going to be talking about. But there is just not one BRCA1 or BRCA2 mutation. Literally, there are hundreds and up to thousands of different alterations. And you have to be very, very specific that the lab that you're sending to does a gene chip and looks at all the various potential mutations that you may be dealing with. One of the problems that we have, and actually I think you know the company just went bankrupt, was the direct-to-consumer genetic testing by a company that offered ancestry and other genetic testing to the public without a physician's input. The problem was they were only offering a very limited number of mutations when you sent your saliva sample to them. So I don't think personally that the FDA was fair in allowing them to offer genetic testing because they were not really looking at the whole package of genes. So here's just an example of a report you might get back just from one company where they talk about pathogenic mutation. And again, you can see it gets very detailed. It gets into very specific transcripts and alternate and inversions in the genes. So again, if you're going to be doing this, make sure that you are comfortable understanding the reports that you're going to get back and how they need to be interpreted. So here's where we are today, I think, with prostate cancer. The earliest work done by Colin Pritchard, which is now only about 8 or 9 years old, was in germline testing of men with metastatic castrate-resistant prostate cancer, and he was able to show that many men had a BRCA2 mutation, some had a BRCA1, and others had CHEK2 ATM. But as our friend Oliver Sartre likes to say, there's a very long tail of mutated genes. We just tend to focus on the more common ones because you're going to see that as the different drugs get approved, they focus on the much more common mutated genes. When you get to somatic mutations, you can start to see that more and more patients in the tumor itself will show mutations in DNA repair alterations. And again, when we talk about HRR gene mutations, we're talking about basically DNA repair alterations, homologous recombinant repair. A lot of these terms refer to the same mutated genes, but they may be used in different abbreviations. So where are we with this? So with prostate cancer, about 10 to 15% of patients with prostate cancer can have a hereditary component. Doesn't necessarily mean that is a clear Mendelian inheritance, but there is a suggestion there may be a familial preponderance to the cancer in the individual's family. Most of these are BRCA1, BRCA2, as we talked about, but a very important concept to remember, because we still don't have this answer today. These mutated genes do not cause cancer. We still do not know what causes prostate cancer very, very specifically, like we know for other cancers such as smoking, sun exposure, and things like that. However, if you've got these pathogenic mutated genes, they somehow interact with the environment and other genes to make the cancers more aggressive, more lethal, and on the other side of the coin, more likely to respond to some of our new therapies that we'll be talking about today. So we do genomic and genetic testing for therapeutic options primarily today, but increasingly for screening, not only for the individual, but for other members of the family, known as cascade testing. So here's kind of a sort of the short list of mutated genes that are commonly mutated. And again, most of them, as you can see, relate to DNA repair, DNA response. There is one truly inherited prostate cancer gene, and that's the HOXB13 gene, and that has to do with androgen regulation. That is the gene that was discovered about 8 or 10 years ago in men who have multiple members in the family who present with aggressive prostate cancer, often less than the age of 50 to 55 years of age. So that is truly the inherited prostate cancer gene in our terminology today. However, most of the other ones, as you can see, are in the DNA repair pathway, including the ones down there, the MLH1, MSH2, and so on, that are related to the Lynch syndrome, which also has a connection with prostate cancer. So most of the mutated genes, whether in the germline or in the tumor, are DNA response genes. They interact with the environment or other features. The cancers are almost always aggressive, higher than a Gleason score of 7 or 8, almost always metastatic, and almost always associated with a poor survival as the years go on. But they also increase the risk if it's in the family of not only family members coming up with prostate and other related cancers, but also the individual might be at increased risk for pancreatic cancer, something they don't think about. In fact, I had two brothers who I did prostatectomies in the 90s. I heard from them many years later that both of them had died from pancreatic cancer. Of course, we never really had all the connections, but I've seen this in men with prostate cancer that we've cured go on to develop pancreatic cancer, because again, these are related to these mutated genes we're talking about. So here's a very, very good paper, if anyone doesn't believe that germline mutations in ATM or BCR1 or 2 distinguish risk between lethal and non-lethal prostate cancer. This is all men, whether they were treated or not treated, and that x-axis, you have to look at it, goes out about 25 years. You could see that the men, even if they were treated, who had mutated germline mutations did worse than men who did not have these germline mutations. Now, when you actually try to look at your radical prostatectomy specimens and actually try to identify how many men really have the mutated genes in the very early prostate world, again, it's actually relatively low, and it's almost always associated with high-risk disease. However, if you identify it, it kind of gives you a direction to how aggressively that you may or may not want to treat that patient with localized prostate cancer. I'm just mentioning polygenetic risk scores because they are related to genetic testing and genomic testing. However, the polygenetic risk scores actually also look at SNPs, which are single nucleotide polymorphisms that gives us all different color hair, different color eyes. And when you put these together in different computer algorithms, you may be able to identify men who might be at increased risk for developing prostate cancer. Again, this is evolving technology. It is commercially available, but this is not purely genetic testing. This is looking at genomic and genetic testing, combining it with single nucleotide polymorphisms. Again, very powerful, I think, right now for potentially screening, but not necessarily very useful right now for treatment decisions. Next, let's talk about inherited risk, because that's a big concern. We all have patients who come in and say, man comes in, 75 years old, has prostate cancer. Gee, I have 3 sons, 8 grandchildren. What should I tell them? So this is a very important concept in daily patient care. As we mentioned, about 10 to 15% of cases were hereditary, and often due to a single inherited genetic mutation that increases the lifetime risk of developing prostate cancer. Familial is where you kind of get a sense there's a breast cancer here, there's a colorectal cancer there, and maybe there's something going on in the family. However, in spite of everything we're talking about, the majority of prostate cancers are still sporadic today, 70% at least, possibly more, without any identifiable genetic component. However, when you do identify it, it's very important to use that information to care for your patient in the best way possible. So here's just an example of a familial prostate cancer where there's kind of clustering. Hereditary, where you can clearly see that there is likely a Mendelian inheritance of a susceptibility gene. Again, minority of patients, but when you do identify it, very important. And I'm a big believer in using genetic counselors. I'm not a geneticist. We're very lucky, most of us that work at NCI-designated cancer centers have genetic counselors that you can bring in and help you. That man who comes in and said, I have several boys and several grandsons, what should I do? They can help you decide who needs genetic testing. And one concept that I think I address all the time in my clinic is that if a man with high-risk prostate cancer has had genetic testing and there's no identified genetic component, there is probably no reason to do what's called cascade testing. That is, check other members of the family. It causes a lot of extra anxiety, but again, this is something that we like to rely on our genetic counselors to help. So if the man has an identified germline mutation, then maybe you want to have a discussion about potentially genetic counseling other members of the family. We've been talking a lot about breast and prostate cancer. Clearly, these mutated genes are much more significant in breast cancer than they are in prostate cancer, as you can see from this graph. However, you can see that they are important for pancreatic cancer, male breast cancer, and of course, prostate cancer. They do increase the risk across the board. Next, let's talk about some of the practical aspects of genetic testing. If you're going to be testing for germline mutations, you're going to get reports that are going to come back that say pathogenic or likely pathogenic. Why is that important? Because that probably means this gene has been identified in the gene bank as being something that can cause a higher grade cancer with time. If you get a benign report back, you can probably be rest assured that there is really no mutation in the patient. The problem that we have in urology, if you have a VUS, a variant of unknown significance, that is a gene that is in the gene bank that has been reported, but it's not clear yet if it's benign or pathogenic. And again, this is where I think we have to rely on genetic counselors and certainly our commercial sponsors who do genetic testing to help us follow up on these patients who come back with the VUSs. As time goes on, the VUSs are actually becoming less and less as there's more and more testing being done. But again, it's important to know how to interpret the test. So here are some just germline testing panels, and this is just a handful of some of our commercial sponsors. You can see most of them look at the main suspects when it comes to germline testing. Most of these done with a saliva collection, some are done with a blood collection. Somatic DNA tumor testing takes things to another level. This is where you have to get the primary tumor or a metastasis, send it to a laboratory, and have them interrogate that for a somatic random mutation in the tumor. And again, this is very important. If it was not for somatic tumor testing, many of the drugs that we're going to be talking about later today, and particularly the PARP inhibitors, pembrolizumab and the like, would not have been approved. Those of you who are familiar with somatic testing know that you get this big report back that is, most of the companies give you hundreds and hundreds of genes. But what's also good, most of the companies tell you clinical trials that are out there that your patient may be eligible for. So somatic testing really gives us actionable gene mutations. Most of them are the HRR genes. And again, when we think about this, it's pretty much PARP inhibitors come to the top of mind. And again, if it was not for these classic HRR gene mutations and many years of research, the PARP inhibitors would really never come into being. Liquid biopsies, again, medical oncology does this a lot more than we do, but again, it is proving itself to be useful depending on what you're doing in the cycle of treatment of a patient, where you can get a sample of the tumor from the blood. And again, this is mostly for patients with advanced or refractory prostate cancer, and whether it's cell-free DNA or exosomes or circulating tumor cells, a lot of that's not really clear, but nonetheless, there is a good correlation between matched tissue biopsy and blood test. These are some more commercial assays that are out there. Again, you can see that both tissue and liquid biopsies are coming out from more and more companies to help us guide treatment of patients, mostly with advanced prostate cancer. So there's really no ideal sequence to identify prostate cancer patients who may have an HRR, BRCA1, BRCA mutation. The fresh metastatic tumor biopsy is probably the best, but again, most of the time we're not, biopsying patients who have positive lymph nodes. In particular today, I have to say with PSMA scans, we used to do it a lot more, and I think PSMA scans are actually not doing fresh metastatic tumor biopsies as much as we used to. Circulating tumor DNA can be used. Archival biopsy of the primary tumor tissue and is probably available to most patients. And again, not the best if you have fresh tumor, but nonetheless, what we have for most patients. And again, blood or saliva pretty much is limited to mostly germline testing. Lastly, just to wrap up on where this is all going, genetic and genomic testing, this is an overview of precision medicine. And again, you see many different variations of this algorithm, this pathway. Howie Scher actually came up with the original model, but as you go from left to right, you get to more and more advanced cases of prostate cancer. But as you can also see in the lower right-hand corner, our more advanced, particularly second, third, and fourth line treatments rely heavily on the use of genetic testing to see which patients are available for which potential treatments. So really, this comes to the core of precision medicine. I'm telling the residents every day, you're just being introduced to this, and this is going to direct probably everything you do in the next 10 or 20 years in the practice of urology, urologic oncology for bladder, prostate, and kidney cancers in specifically, where you identify specific genetic alterations and then designed treatment plan for them. So when we talk about the PARP inhibitors, we are talking about poly-ADP ribose polymerase enzymes that are activated in the prostate cancer cell. And here's why PARP is important. PARP is important because if someone has a mutated BRCA1 or BRCA2 gene, or some gene in that category, what happens is that when that cell's division starts to go awry, the PARP comes in and allows that cell to continue to divide. So it's almost like the PARP in the cell is like a rescue swimmer in the Coast Guard or something like that. It allows the cell with a mutated BRCA1, BRCA2 gene that is becoming malignant to continue to grow. By inhibiting the PARP, you're putting a blockade up to that rescue enzyme to allow these malignant cells to grow. And again, if it wasn't for genetic testing, we would not have this. And again, the DNA repair genes make proteins that repair double-stranded DNA breaks, and that's also the HRR we keep talking about. And the poly-ADP PARP inhibitors, important for repairing single-strand breaks, but again, if you can stop them in a cell which is malignantly transformed with a BRCA1 or BRCA2, you have a chance of killing that cell. This concept is called synthetic lethality, and I've seen about 18 different diagrams, and all of them confuse me, and I think for me this is the simplest one. If you've got a cell which has undergone DNA damage, and it has a mutated BRCA1, a BRCA1 or BRCA2 gene, PARP will come in there and rescue that cell and allow it to keep growing on its malignant pathway. However, if you block the PARP, you have a high chance of killing that malignant cell. These are our two PARP inhibitors that were first approved back in 2020, olaparib and rucaparib. That's 5 years ago, so these drugs have actually been around for quite a while now. The other thing that's out there in the somatic testing world is microsatellite instability. And again, pembrolizumab is available for these patients. You can also look at Lynch genes that we talked about earlier, again, by immunohistochemical. It doesn't all have to be genomic testing, but you can stain. And again, many of us that work with upper tract urothelial carcinoma know that in patients with Lynch syndrome who are at increased risk for colorectal cancer, also increased risk for upper urothelial carcinoma. And again, those samples, are teeny-weeny. We can actually do immunohistochemistry and identify these DNA mismatch repair genes. And again, not common, but when you identify a man through somatic testing who has microsatellite instability high or the Lynch gene syndrome, they have a pretty good response rate to pembrolizumab. Not common, only a few percent, but they can work. Lastly, here's practical information on clinical trials. All of these trials that you've heard about, the Triton trial, Magnitude trial, Propel, all are based on PARP inhibition showing improved survival. Here's just one example of rucaparib from the Triton trial that showed an improved survival. The hot topic today, though, is combining PARP inhibitors with androgen receptor pathway blockers, and we'll be talking about that a little bit more today. Two big trials were Magnitude and Propel, and again, you'll get more interest, today discussions as the day goes on. But again, if you look at where we are with FDA-approved therapies, either monotherapies or combination therapy, all of the genetic alterations we've been talking about the last 20 minutes are key to the approval and the clinical utility of using these medications with men with advanced prostate cancer. And again, treatment outcomes with or without somatic germline alterations. Again, for first line, it doesn't matter how you treat the patient, whether they have a BRCA mutation or not. It doesn't have an impact. However, when you get to the second and third line treatments, that's where the genetic testing really makes a difference. And lastly, I found this slide on the internet. I thought it was kind of cute, and I figured out how can I use it in this lecture. But there's all sorts of different ways for you to look at genetic testing guidelines. There's literally dozens of them out there. But since we're here at the AUA, and the SUO course, if you look at our guidelines, if you're going to do germline testing for metastatic hormone-sensitive prostate cancer, metastatic castrate-resistant prostate cancer, again, you need both germline testing, and for advanced disease, you need somatic testing. And again, PARP inhibitors or microsatellite instability high offer pembrolizumab. So these are our guidelines that we'll be going over again and again today as the program goes on. So what's the bottom line? All men with metastatic castrate-resistant prostate cancer, or all men with early high-risk feature, even if it's hormone-sensitive prostate cancer, should have both germline testing and, if the tissue's available, somatic testing. Again, it's probably over, it used to be about 12 to 15%. Now it's probably over 25 to 30% of men with metastatic castrate-resistant prostate cancer will have some type of germline or somatic mutation. The most critical genes today, we've talked about them over and over again. Liquid biopsy, looking for cell-free DNA, exosomes, and things like that's becoming very important. And again, I'm a big believer in genetic testing referral. Many of us don't have that available in our practice. Again, most of us at NCI cancer centers have that available. And again, very recent studies, less than 40% of men with metastatic castrate-resistant prostate cancer get germline or somatic testing. And again, there are several studies out there, the Target study and the Helix study, which is an online tool, again, with the goal to increase the germline and somatic testing of men with high risk and metastatic prostate cancer. So again, I thank you all for your attention, and I hope you can bring some of this home to care for your patients on a regular basis.